have a really wonderful panel here today. It's called Putting Data, Language, and Technology to Work. And our panelists are very diverse. In order to make this as interactive as possible, I am going to introduce each person, say a little bit about their organization, and give the title of their 2-minute abstract synopsis. And I'll do that for each of the 4 people in the order in which they appear in your program, so you know who's who. And then I'm going to ask each of you to do a 2-minute summary, maybe 2 minutes and a half. I've got a timer out there. And then the panelists already sent me some questions to ask them. So I will ask whoever, not saying who, you can, if you all want to answer one question, that's fine. But I'll ask these 6 or 7 questions to get you, the audience, warmed up, because then it's your turn to ask questions. How does that sound? Sound reasonable? It's Mona's brilliant idea, so I hope it works. Okay. The first speaker we have is Lois Varenkamp, who has an MA in linguistics from the University of Texas at Arlington. She's also, in addition to being a linguist, a registered nurse and a cross-cultural manager and administrator. Lois grew up in Peru and lived in Nepal for 20 years, where she and her husband raised their 2 daughters and worked with local believers to translate the New Testament into one of the minority languages in Nepal. She works with SIL Lead as a health consultant. SIL Lead is a faith-based nonprofit helping community organizations use their own languages to improve the quality of life. Their organization works in partnership with SIL International, a nonprofit that works alongside approximately 1,500 minority languages and has done a lot of work in linguistics globally. Her presentation is called, no surprise, The Missing Link, Language Impact on Health Outcomes. The second speaker is Emily Tunggala. Is that okay? Okay, good. She's the product lead at Secure Data Kit, a product of Standard Company. She works closely with Secure Data Kit customers to understand their challenges, takes the challenges back to her team so they can develop solutions to help customers use data in a meaningful way that transforms lives. Secure Data Kit, or SDK, has partnered with the Bill and Melinda Gates Foundation, Center for Disease Control and Prevention, the WHO, and others. She lives in Atlanta with a 6-month-old baby. But she also sent a little example of what they do. Recently, SDK has been used to visualize and share real-time progress of a school-based deworming project in Kenya. These real-time visuals have helped implementing partners make quick, data-backed decisions to improve health outcomes, leading to transformed lives. Her presentation is called Using Data to Transform Lives. All right, the next one is Michelle Kendall, who is with Catholic Relief Services. She's a senior technical advisor for gender and integral human development. She provides technical leadership in gender integration across CRS programs. She holds a master's degree in international affairs from Columbia University, and she has over 20 years of international programming experience in gender and women and girls empowerment. And as we all know, Catholic Relief Services is one of the most long-standing, well-established development organizations that we have. It was 75 years old this year. CRS works in 110 countries with about 1,951 partners in emergency response, health and social services, agriculture and livelihoods programs. CRS works with other Catholic organizations and all in other institutions to assist people on the basis of need rather than creed. Her paper is entitled Smart Couples in Niger, working together to improve family well-being. And finally, we have Dr. James Juha, who's the Deputy Executive Director of the Christian Health Association of Ghana, which is already very famous here. He's a public health physician with an MPH from Tulane University, an MBCHB from the University of Ghana, and an MBA from the Ghana Institute of Management and Public Administration. CHAG was established in 1967. It's a network of 75 hospitals, 209 health centers and clinics, and 19 health training institutes owned by 25 different Christian church denominations, with the main stakeholders being the Ghana Catholic Bishops' Conference and the Christian Council of Ghana. I hope that's correct because I just got it off the web. Okay, good. CHAG provides health care to the most vulnerable and underprivileged populations in all regions of Ghana. And his presentation is going to be A Healthy Nation, Christ's Healing Ministry Fulfilled. Okay, with that. Oh. Oh, I'm sorry. Yes, thank you. Turn the page. Thank you. Thank you. Yes. His paper is 100 Days Free of Maternal Mortality Campaign, What Collaborative Learning Taught Us in Christian Hospitals in Ghana. After the presentations, I'm going to give out these 5 or 6 questions. And the first one was submitted by Dr. Dua, which is, why a 100 days campaign and not, say, a 1 or 2 day campaign? So that's just sort of an entree to help you start thinking about your own questions. Okay, with that, I'm happy to introduce Lois.
Thank you very much. It's great to be here, really an honor to be up on this platform. I've learned so much from people up here, and look forward to hearing from my colleagues too. I think the fact that we're all gathered here is an indicator of what we share, that we believe that health is a driver for improving lives around the world and for expressing our Christian faith in the midst of the world that we live in. We also understand that mothers and children are often particularly vulnerable to failures in healthcare and also access to information about health, and as well as just accessing care. But what is sometimes overlooked is the foundational role that language can play in access to healthcare and critical health information. So that's one of the passions that SIL lead, the organization that I'm representing today, and I personally have. There's a phrase that I've encountered in African development articles, and it's, there is no development without communication. And I love that. And it plays out, that's a truth that plays out in many ways in the global health arena. For example, in the Ebola crisis and response, both in 2014 and more recently, language is one of the barriers that healthcare providers have encountered in trying to give crucial information and intervention. Translators Without Borders is another organization, and they've done some research on the comprehension of health materials that have been distributed in the effort to help with the Ebola crisis. And they've shown in one area in Goma, in the DRC, that instructional materials in French and standard Congolese were not well understood by people. And in particular, women had difficulty understanding posters and even the terminology in spoken instructions. And if there had been it was a good effort made to give multilingual information, but it was not what that particular area could understand. And if there had been an effort to test the materials and turn them into a local Congolese that would be understandable, it would have had a much greater impact on the people that were the target audience, I don't like that word, but the people that were the focus. Thank you. Excellent. Focus. I like that.
I have to interrupt you here because I think you're 2 minutes.
Oh, well
I'm
then.
Sorry, it's very brief. Now, if it doesn't work out, we won't do it this way again next year.
That's
but,
fine.
2.5 to 3 minutes.
Okay.
Thank you.
Mhm.
Emily.
Hey everybody, I want to echo what you said. We're so grateful to be here. This is our first year here. We've loved meeting all of you guys. And if there's anybody here who we haven't met, we have a booth over there and we'd love to get the chance to meet you guys in person and learn more about what you guys are doing. So at Secure Data Kit, our mission is to transform lives with data. So naturally, we've found ourselves working with a lot of global health organizations, nonprofits, and churches whose mission is very similar. It's to transform lives. But what about this data piece? What is missing? So we believe that nonprofits are in a really unique position to be able to leverage data tools to transform more lives. So if your number one goal is to transform lives, we know that you can do that. That you can go to someone, have a conversation, learn what they need, and transform their life. But you're transforming one life, or you're transforming 10 lives. So what about the data is so important? Well, data gives us a bigger picture. It gives us a higher level view. It's the data that enables us to identify areas of need that we may have not known were there. It's the data that enables us to anticipate need and then do something to prevent that thing before the need even arises. And we're all nonprofits, so we also need money. And it's data that justifies those donation dollars, and not just justifies the ones you already have, but allows more donation dollars to flow in so that you can actually make a greater impact with your funding. The thing is, though, it's not just data. It's not just numbers, ones and zeros, spreadsheets, and charts. Behind every single record is the story of a life. It's a life that's being transformed or has already been transformed by the great work that you guys are doing. So as nonprofits, we truly believe that it's your responsibility, and it's our responsibility as well, to be really good stewards of that data so that we can use it to transform exponentially more lives.
And they can go next door.
Yeah, you can go next door. This little thing is in your tote. You can look at that. We'd love to tell you more about the product that we're offering. And also tomorrow, my colleague Nikki, who's sitting there, is hosting a theme table at breakfast where we're going to talk about how you guys are transforming lives, and maybe we can figure out ways to kind of add data into that so you can transform more.
And the special offer?
Oh yeah, special offer. So since you're at this, thank you. Since you're at this conference, we are giving away the use of our product for the first 3 months for free. After that, it's still free up until you collect 1,000 records, and then it's affordable after that. So definitely talk to us. We'd love to meet you. Yeah. Yeah, thank you.
Thank you very much. Michelle,
Okay.
over to you.
Good afternoon, everyone.
Share.
Yes, thank you. So as was said, my name is Michelle Kendall, and I want to thank the organizers for the honor of being here. I think CRS has participated in this forum before, and we always look forward to being a part of this conversation. So challenge, 2 minutes. So I've put my thoughts down on paper. So I'd like to talk about a faith-based curriculum that CRS has been using for a number of years called the Strengthening Marriages and Relationships Through Communication and Planning. It was developed and it's used to coach and support couples and households in better ways to communicate and adopt shared decision-making in their households in areas such as health, nutrition, natural family planning, agriculture, et cetera, a whole range of issues, as well as even household economics. We've used the approach in about 14 countries over the years and reached countless households. 150,000 is kind of the number we put out, but in any case, the approach has 2 curricula. The first is called The Faithful House, which we use with majority Christian communities, and the Islamic Family Life, which again uses many of the same faith-based principles. Just to tell you a little bit about it, it can either be administered as a 2-hour daily sessions for about 2 weeks with cohabitating couples, or can be done over a 3 to 4 day period. The session includes topics such as faithfulness, love, respect, communication, reconciliation, forgiveness, many of these issues even before we speak about a specific technical areas such as health. It's also followed up with time for the couples to communicate, to reinforce what they've heard through the particular session. After the training, the couple facilitators follow up at home visits, they establish a support group, and couples who are trained reach out to other couples through a variety of fora, which is after church services and in other community venues. Wow, 2 minutes goes by very fast. So I'd like to briefly share our experience in combining the Smart Couples approach with a natural family planning approach in remote communities in Niger. Before going further, I would like to say that the approach was developed by CRS and Georgetown University's Institute of Reproductive Health. The natural family planning piece was very much led by the Georgetown and the Institute of Reproductive Health. CRS basically came in with the couple strengthening part. Basically, the couple strengthening and the natural family planning was offered at the community level, and the idea, again, was to improve couple communication and planning around child spacing. We also worked with local religious and community leaders, and basically all of our work were through religious and community leaders. And just a few things about what we found. I really liked one of the pictures that we saw was about we're faith-based and evidence-based at the same time. So we found that actually the model allowed us to reach very remote communities. About 1/3 of the couples were young couples, particularly hard population to reach. Niger, as many of you will know, has the highest fertility rate in the world, so clearly a critical issue. And the study actually showed that there were significant increases in couples' communication around child spacing, increased uptake of many of the natural family planning approaches. I can talk more during the question and answer session, but certainly a pilot, but we already saw quite important impacts. Thank you.
Thank you very much. Very happy to be here to share our experience in a program that led to 24.8% reduction in institutional maternal mortality in Ghana. So at the end of 2015, it was clear to Ministry of Health Ghana that we couldn't achieve the targets of the MDGs, specifically for maternal and child health. And so Ministry, with support from EU and Danida, came up with a program called MDG Accelerated Framework for Maternal and Child Health. And they had specific interventions that all the service delivery agencies in Ghana were supposed to implement. So train doctors in obstetric surgeries, train midwives and nurses in ultrasound scan, train midwives in implant insertion, and other training programs, and also support facilities to become emergency obstetric and neonatal care compliant. So Ministry was supposed to supply equipment. So CHAG was part of this program. But when we saw the interventions, it was clear. These were interventions that had been implemented many years, and we are getting the same results. So if we did not achieve MDG goals, and now you want us to implement the same interventions again, it was clear that we're going to get the same results. So we asked ourselves, how can we do things differently in order to achieve the result that the ministry requires? The first assumption was that in every institution, the causes of maternal mortality was not the same. And so we can't implement the same programs. Number two, we assume that we can use the HSS CHAG, we use 9 instead of 6. So leadership and governance, service delivery, we include community participation and partnership and research, as Peter illustrated this morning. We're going to use this. And then, thirdly, we said that if we form teams in the hospitals, they can identify their own problems and then come out with interventions which they can implement to address those problems. So we form teams. Now, we said that if maternal deaths occur, that is a failure. So how can we go 100 days for each of the institutions without recording maternal deaths? So it became a campaign. Now, every 100 days, we were meeting a team of 5 from each of the hospitals. You come, you tell us what you will do, what measures you put in place, and how you fare. So the successes and the challenges, and then we bring all the teams together. So we learn from them. We also assign 21 specialists. Each of them, we assign 4 to 6 facilities. Every month, you provide support, whether telephone conversations or site visits. And then we created a common platform where if you are a hospital in a very remote area, you have a challenge, you put on the platform, specialists are there, midwives are there, then they tell you, do A, B, C, D, or refer to this facility. And on the platform, people are alert. So if you refer here, before the patient goes, the facility is aware that they are coming. With this, by the end of first 100 days, 83% of all the hospital did not record maternal mortality. In the second 100 days, 80% did not record maternal mortality. At the end of 1 year, 24.8% reduction in institutional maternal mortality. Deliveries had gone up by 24% from 110,000 deliveries to 136,000 deliveries. Stillbirth rate had reduced by 4.8%, and family planning acceptance rate had gone up. And a lot of the facilities receive support in terms of equipment. I think I'll end here.
Everybody in our panel has success to be proud of, so thank you so much. I am, sorry. Oh, okay. I'm going to start off with the question that I promised you I would, which was to Dr. Dua. Why a 100 days campaign and not, say, a 1 or 2 year campaign? I think you've already partially answered that, but just give us a bit more information.
So typically, for most of our institutions, we wait till the end of the year to review our reports, and then we make interventions why we failed, and then put in 1 or 2. But the issue is, 1 year is such a long time. So if you review your programs intermittently, you can reduce a lot of the debt. So when we did the assessment, we noted that every 20 days, some facilities were recording deaths. Some were 30 days, some were 15 days. So how can we go 100 days? 100 is, it looks nice. And 3 months, we thought it was such a good time to make interventions. So that is why we chose the 100 days, to make it more rhyming and everything. Yeah.
And it worked. Now we just have to put your data on your system. Right? Okay. I have another question here. How can nonprofits utilize technology to maintain monitoring and evaluation activities despite local turnover?
That's for me, isn't it?
That's for you.
Yeah, so in all of our work with nonprofits and even larger global health organizations, there's a common problem that the people on the ground, often the people doing the work, they don't stay very long for various reasons. And so people are really hesitant to pick up and adopt new technology because there's this stigma, I guess, that it's going to be really hard to get off the ground and people are going to have to be trained to use it and all of that stuff. So our suggestion is always to start as small as you can with the technology that you're choosing. So many nonprofits have all these grand ideas for how technology should be implemented in their organization, and they're really good ideas, and we think that one day, hopefully you can get there. But our recommendation is to just start small. So if you're not collecting any data, just start collecting some data, and choose a piece of technology that's really easy to get off the ground. So ours with Secure Data Kit, literally all you have to do is log in with a username and a password. And in our experience with social media and all that stuff, everybody knows how to do that. Some of these bigger, more robust technologies can do a lot of things, but it takes a week-long training and someone to fly into a rural place to train people how to use it, and that's just really not necessary. So our suggestion is to start small, find something that's just easy. You don't need training. Someone just logs in. And then next, we think it's really important to incentivize the people who are doing the work, not with money. None of us are here because we're getting paid tons of money, but incentivize them with the data. And not the boring part of it, but really what's happening, what they're doing. So like, good job. You transformed 27 lives this week because you gave 27 kids like the healthcare that they needed, that they wouldn't have otherwise had. And I think like as humans, like we're all driven to do great work because of the lives that are being transformed. So I think like opening up the data that you're collecting to the people doing the work and not just like housing it in some corner office somewhere, we think can make a really, really big impact. So.
Excellent. Thank you so much, Emily. Thank you. I'm going to save a hard one for you till the end, if you don't mind, because I'm going to ask language. How can projects strategically plan for language issues that may affect outcomes? You know, in our own country, we have language issues around health that affect outcomes, don't we? All right, so over to you. Okay. Solve the problem.
Oh, yes. Okay, in 2 minutes or less.
Oh, you got more time. You got
okay.
more time.
Well, I would say the beginning, the first thing I'd like to say is the important thing is to start at the beginning, at the planning phase, to include language issues and identify them and address them, because it's halfway through a project and you encounter language barriers is a much more difficult time to address them than at the beginning, when you can have the freedom to budget, to find donors that are interested, to make a case. So I think that would be my first thing, and to include that in budgets. To prioritize vulnerable populations. I think everyone here is looking at vulnerable populations, right? And minority language speakers tend to be invisible in many ways. They find the same difficulty accessing education, information, and healthcare. And they just are invisible because it costs more to find them, and they don't necessarily know when they're being, when there are things to offer to them. So identifying those, there's technology that can help us do that. There's the Ethnologue is an online database of languages of the world. Anyone can access that, and has language maps that show where languages are distributed. So that's a good place to start. SIL Lead can offer consultancy to help identify those populations and how they might be able to be included in a project, so that we don't increase this social divide between the haves and the have-nots. We don't intend to do that, but it can happen just because they don't know that what is available to them. And employ local resources, that human element of the people that are multilingual already and can help. We can look for that, but we also want to make sure that they're well trained, because there was an example of in the measles outbreak here in the US, recently there was an article that pointed at some materials that were developed in Yiddish in New York City. And they were door hangers and posters. But the door hangers were actually, they tried to do their work. They solicited help from a translation agency, but it was so poorly done that it was almost incomprehensible to people. So it could have potentially been offensive and actually created a distrust, rather than actually testing those materials and making sure that they communicated. So using local resources, but making sure that they're well trained to do what you're asking them to do.
Thank you, Lois. Thank you very much. Take a big breath now, Michelle, because a couple of you had the same question, which was, what is the most impactful innovation that you have seen in global health in the past 5 years? And we'll start with you, if you don't mind, Michelle, but everybody is invited to add your own perspective to the most impactful advance that we've seen in public health in the last 5 years. And it's not measles vaccine, right?
Yeah, that's a hard one. And I'm not a public health expert, so maybe I'll give the non-technical perspective. And I'll link it to perhaps what is the second question that you may have, which is the role of the community and reaching into households through the community. I really liked your explanation of the 100-day campaign and how you had improved the quality of service in hospitals. And as I was listening to that, because we also work in Ghana, I was thinking about what a wonderful link as we work with communities, right, to increase the uptake and participation in health systems, that when that mother or that couple family gets to the health facility, they're actually meted with quality care, right, through the work that you have done. So what a wonderful linkage. So I would say it may not be the most impactful, but certainly something that we've known is that we've gotten a lot more cognizant, and we've tried much harder to reach, if some people say the last mile, but really working with and through communities to really sustainably create that demand for quality services. It's not just a technical fix, it's important, but that it's that partnership with understanding what motivates people to seek health care and how we can really work with communities and families to do that.
We've heard a lot about communities, and what I've also heard more clearly this morning than ever before is to be community-based is not enough. It has to be community-owned. Something else that I heard this morning, which is from an old friend of mine, it's not mine, but Phyllis used to say, think big, start small, act now. One final question. Are there lessons from Ghana and for other countries and other Christian health associations that would help them also reduce maternal mortality? You gave us a lot of ideas about the 100 days being a manageable length of time. And I liked your peer review and your discussion about mortality, the death audit. Those were wonderful ideas. Is there anything else that you'd like to add to the other folks here who also are concerned about maternal mortality in their own countries, which I think many of the countries are not quite as advanced as Ghana is. Is that right? Because you're now lower middle income, right? Yeah. Welcome to the group.
Thank you very much. I think one of the first things that we recognized was the fact that we cannot develop interventions from top down. Contexts vary. And it's also very important for the people for whom you want to develop intervention, for them to identify their own problems and come out with ways that they will solve them. That gives them a sense of ownership. We have identified our own problems. We are the people that can solve our own problems. In a way, it has inherent sustainability issues because we know what it is, we can do it. How can we even put in place intervention that will not cost us so much? And I think to end, there's this guy, Kuzus and Posner, wrote a book on leadership challenge. It's very inspiring. They talk about 5 exemplary practices of leadership. And one of them talks about modeling the way, inspiring a shared vision, challenging the process. For us in CHAG, leadership plays a very critical role in inspiring a shared vision. So for this particular campaign, when we're talking about can all our facilities travel 100 days without recording maternal mortality? Everyone was running with it. My executive director here, even though he's very busy, but he made sure that in all the 100 days meetings, he was part of it. I mean, to give that sense that we care about what you are doing. In challenging the process, everybody does it this way. How can we do it differently? If we keep on doing the same thing over and over again, we are going to get the same results that everybody is getting. How can we challenge the process if we want to get a different results? And then when people have worked so hard, when they are doing so well, everybody has that, I mean, we want to be patted on the back. We are doing so well. And so those meetings, 100 days meeting, were meetings that we patted on the back of the staff, even though they did not receive any awards, but to say, hey, you are doing well. How can you teach the other facilities? Thank you very much.
Thank you. Those are all the questions that were submitted by the panel, I think. Hope so. Now it's over to you, to the floor. Any questions that you would like to ask of any of the panelists? While you're thinking, I want to just point out again, your community ownership is almost like the theme of the day. It's only halfway through the day, but it's a very important theme. Thank you. Anybody else? Yes. Oh, here, why don't you come in?
Hi, my name is Alexandra Gordon. I'm with the J.C. Flowers Foundation. And I decided to raise my hand up here after your community ownership comment and this theme that we've been seeing. So I think there are indicators and things that are easy to measure, especially in global health, like number of people treated, number of people tested, et cetera. And we do a lot of work around community ownership and community engagement. And I'm wondering if anyone here on the panel has had experience trying to find some way to measure that or some way to prove to a donor that community engagement is important because of XYZ, or this is how we measure community engagement. So I'd be curious to hear anyone's thought on that. Or community ownership and community engagement, which are similar, I think.
Very similar, yeah.
So again, let me refer to this particular program. We noted that in some regions in Ghana, now Ghana has 16 regions. In some of the regions, blood and blood products were a big issue. And if you read maternal mortality reports in Ghana, hemorrhage is the leading cause of maternal death. And so trying to get blood for blood transfusion was a very difficult one. But through this campaign, some of the facilities went to the community and told them, your women are dying because when they get to the facility level, we are not getting blood for them. Now, blood is not something that is manufactured in the lab. It has to come from this community. How can we help raise blood so that we can help our mothers survive? We believe that no mother should die because you are giving birth. And what happened? There were voluntary donations. Some of the facilities had their blood banks full of blood, to the extent that they were sharing to other facilities, even to GHS, Ghana Health Service facilities. So that is the community. You tell them the problem, they are the people whom the services are for, and they are the people that can help. So in every aspect that you look at it, the community plays a very key role in our interventions.
Just one study that comes to mind, I think including Indigenous languages in health efforts can be kind of easily measured if you collect the right data. There was a child stunting pilot study using Indigenous languages to communicate nutritional needs for children. And it was, I think, a 10-year study, and they decreased the child stunting by 50% in those communities, and it had been an entrenched problem. So I think some of those kinds of things that you have a clear change in what is being tried and collect the correct data, it can be really instrumental in helping donors see the importance of that intervention. Sorry.
Yeah, another, I'm just going to add, yes, Sally, go ahead. But underlying this is get your baseline data. Because we're so eager to start sometimes that we forget to measure where we are, and it's critical.
I'm Sally Craig Huber, a retired member of CCIH. I want to pose a reverse challenge. We've learned from Dr. Dua about preventing maternal mortality in Ghana. Lately, we've been seeing a lot about the disparities in maternal mortality in this country. And as the table is people who live in this country, I'm wondering about your thoughts on what we could do better with language, with data, with communication to address maternal mortality challenges in this country.
That's a wonderful question. I think we should all move to the villages.
So I can. let me do a quick disclaimer that I'm also not a global health expert. I'm a technology person, so I don't have the global health answer for this. But one thing I can say is a lot of global health experts use our platform to do surveys, and they're asking populations about their health. And one thing we've seen is that so many times a missing question is, what is your gender? So they have so much great data about these populations, but we don't know if that data belongs to a male or a female. And so I think that's a super easy place to start, because then we can begin to see like 50% of these records like have this one thing that, who knows, it might contribute to maternal mortality. We don't know that because we don't know if it's a woman that's talking about or a man. So I think that's just like the simplest place to start is if you do begin collecting data, like ask those basic questions, like what is your gender? Yeah.
That's a really good point. We struggle with that in CRS, especially if you're collecting global data and agency-wide data. Getting gender disaggregated data is more difficult than one would imagine. But to your question about looking at the issues here, I completely agree. And I would say for Catholic Relief Services, we have what we call our international arms. We work overseas, and then we've got Catholic Charities that works in the U.S. And I'm encouraged by your observation, because I myself, have that observation that often we're looking outward, and we might also look at what we can learn from what we've done overseas here, frankly. And there's been so much incredible community engagement work that's been done and increasingly recognized and valued. And I think it's to some extent, there's a lot we can apply here. So I don't think we're doing enough. I don't know if that's not a great answer, but I know within our headquarters, we are recognizing that there's more that we can do domestically. If not in the health field, certainly we have a large peace building program where we work on social cohesion and community sort of building, bonding at the community level. And we're realizing, hey, we work in Baltimore. There's a lot we need to do here around social cohesion. So just to let you know that awareness is growing. So, yeah.
Just two things. One is, first has to do with communication. So at the community level, like the international aid community wants the localization of aid. That's a big topic right now. So you talked about community-based implementation, but what that implies is that there has to be a language that's understood at the community level, at the indigenous level, at the minority language level, but more than that, just to speak the faith language. Because the international aid community does not speak that language. So there has to be a translation from the international aid and development community into the faith leaders and community level. So that's one thing. And the second is, data is one thing, but if you take raw data, it's completely useless without a narrative. So part of the narrative is the analysis of that data. And data doesn't persuade as much as the data within the narrative. And that's where I would propose that the discipline of publication taps into existing knowledge, creates a narrative that flows, that is more persuasive, and that the discipline, I think, is a valuable thing for us to consider in terms of the analysis of raw data. I don't know if that's a question, but I would like to see what your thoughts are on that. Thanks.
One thing that comes to my mind, just briefly, is it on? It's on.
Jenny, is this on? Hello.
Okay, I don't know. Okay, I got it. There you go. Sorry, my progressive glasses aren't working for me. One of the things that comes to my mind is the fact that narrative is also important to reflect back to the communities where that data was gathered, so that they can learn from it. And again, waving the minority language flag is sometimes the people from whom it was gathered don't understand the languages of wider communication, and somehow making the effort to make sure that it's communicated that it mattered. Whatever happened that improved their lives actually did on a wide scale make a difference. And I think that's a really important thing, even in our own country, when we see ethnic divides in healthcare delivery, maternal mortality is much greater in some ethnic groups, making sure that that gets communicated, that when you deliver in a healthcare facility, maternal mortality goes down, or if you have those kinds of things, making sure that that narrative gets back to the focus audience.
Yeah, I feel like it's, of course, important to share the story behind the data, right? Another level to that is also the frequency with which you're sharing that story, I think. So often we wait until our annual report comes out and we have like a really nice brochure with beautiful pictures and some really great big numbers of the lives we've transformed. But I think, we have technology now, we have social media now, and we can be communicating this every day, every week, and say today, like 27 kids got medication or whatever. Like, we can communicate it way more frequently, and I think that's another level to sharing that story.
So we can generate the data, but at the target and what form of communication to use, it's an issue. If you generate statistical data, purely numbers, there should be a certain category of people you are speaking to, the educated, because they will understand it in that sense. We can convert it to moral, and if we are talking to the religious groups, or emotional if we are talking to non-educated. So the format of the message, it's very important in eliciting response. And I think over the years we have used maybe research, this is data, this is statistical numbers, and we are communicating to everybody. So we don't get the response that we need.
Yeah, because numbers mean very little to many people. Yeah. But that's why I like the lines and the charts and things, so you can see what happened in December compared to what happened in March. Yeah. Any other questions? Oh, yes. Thank you so much. Thank you.
I'm Angela from Nigeria. I want to add something to the language barrier. You see, when we say that somebody is an illiterate or literate, what you do not know, you are an illiterate in that aspect. Medical terms, people that are not of the medical line, most of them are illiterates. I'll start my story with this story. There was a lady in our hospital. She had an abortion. The husband, who is a rich man, but has no idea about abortion, came and asked, "What is wrong with my wife?" The nurse just said, "She had an abortion." There was trouble. What language the man understand is what? Miscarriage. So when we are talking about language barrier, we have to think about our medical terms that not everybody knows. So, and that caused a heavy trouble in that family. So let us mind our language terms. What you do not know, you are an illiterate in that aspect. Thank you.
Thank you very much. And it's very sad that we don't know what we don't know. So thank you.
Thank you. I had a question for Dr. Duo, which was basically what platform you said you had created a platform. I wasn't sure if it was like what to communicate. That's my question, but I wanted to add real quick to the issue of translating data or communicating data. I've worked in M&E for a long time, and years ago, I think it's been over 15 years, there was a regional group in Zambia, Zimbabwe, and Uganda that had created what we were calling participatory monitoring and evaluation, that was essentially used to work with communities to collect data. And so I really have a huge challenge when, like you were saying, when we say they're uneducated, because when they're uneducated or illiterate or whatever word it is, it doesn't mean that they can't understand. Communities function. They collect data and understand numbers. The fact that they don't use statistical medical terms doesn't mean that they can't understand it. We used to do priority ranking exercises with literally sticks and stones, on the ground, and people could count, assets that they have and could understand when you use that data and gave them information back in terms of averages and in terms of how you could improve. For example, you could reduce overgrazing, or you could reduce, you could teach HIV in using terms that they could understand, because in a similar way that researchers and statisticians and medical providers don't understand the languages we use in terms of describing our health. I have a problem communicating with my own doctor about my own body, because he's thinking about it in medical terms. I'm thinking about it in terms of the way I feel, which is essentially qualitative and quantitative data. So I think it's really important for anybody dealing with data to understand that people are not dumb, and for as long as you can dumb down what you think they will understand it in their own terms. Thanks.
Thank you. We've got about 3 more minutes. But I think, what did you call that? Participatory? M&E.
Monitoring.
Yeah, that's kind of forgotten. And I think it's really important. Well, it fits so well with what we're talking about here and what you're doing in Ghana. One thing I wanted to ask in Ghana is, there used to be hospitals in the former Soviet Union used to have a little badge when they were baby-friendly hospitals. Baby-friendly hospitals, they had a little flag that denoted they were a baby-friendly hospital doing everything right. Do you have anything like that in Ghana?
Yes, we do. We do. And to answer her question, the platform is WhatsApp platform. Mobile penetration in Ghana is about 138%. Which means that almost every home in Ghana has about 1.5 phones. So even if you are in the rural area, you have a mobile phone. And that is why we decided to use a WhatsApp platform. And we had 355 staff on the WhatsApp platform. We included managers of institutions. My executive director, Peter Eboa, is on the platform. All the heads of institutions are on the platform. And we have a team of 5, administrator, the nurse manager, the head of emergency, obstetrician, and then a midwife who are on the platform.
It's a wonderful way to use technology, isn't it? Yeah.
Can I just add a bit to that? I mean, I think it's great to hear about the 138%. I do want to put together what you also mentioned about collecting gender disaggregated data, and also to build in on the participatory, the sort of qualitative, and really understanding the figures behind the numbers. So I'm guessing that both men and women have equal access to the mobile data. I mean, I think it's fundamentally important. In a country like Ghana, I think that would definitely be the case, but not, for example, in Niger, where it's a huge issue. Absolutely.
You have to become a lower middle income country to get that coverage with WhatsApp. Okay, one more question and then we're going to close. You know what I've just noticed is the wonderful synergies that happen when different people with their different mindsets have the opportunity to hear other folks and what they're thinking. I think that we come out of this a whole lot more enlightened and more committed, and I think more caring and inspired by our fellow human beings, which is really kind of a rare feeling some days. Any other comments before we close? Good, okay. Yes, sir.
I don't know if I dare ask this or not. It's kind of a rhetorical one. But if you could permit me to kind of go out on a limb and make a prediction. When we collect enough global data and analyze it, what are we going to do when it implicates the systems of rapacious taxation and misallocation of resources as significant contributors to instability, unsustainability, and generational poverty? Yes, what I was thinking.
Well, the easy answer is have a revolution.
No, that's not the option. This is CCIH.
All right. On that wonderful note, I'm going to close and thank you all so much.